I love this hour because it's a great opportunity. I learned so much when you're here, and I know our viewers,
Shannon.
you guys have written in and said how helpful this is to you as well, and so I encourage all of you to be participating right now. Our lines are open, and the live feature on the website is open so that you can be asking questions. Because we have you here this morning, we have some timely breaking news, something that I wanted to talk with you briefly as we get to the questions. We already have people writing in questions, so we won't belabor it. But there's a new study that is coming out yesterday and today in the Journal of Child Psychology and Psychiatry, talking about autism and the potential for children to lose a diagnosis over time. And I will say that we're going to be taking this research and talking about it in depth with Dr. Jonathan Tarbox on Friday, exactly how they did the study and what it means and how we can interpret that. But already the news media is jumping on the bandwagon and reporting about this study. And I'm a little offended at the way that already people are describing this. Mm-hmm. Yesterday in the Daily Mail, the headline was, "Children can grow out of autism."
Right.
And I just want to get your opinion because you really are someone in this field who over 2 decades has been there at the forefront working with these children and seeing what recovery looks like. And I want to hear from you about the word recovery, about losing a diagnosis, and this notion of growing out, which, by the way, the study does not say anything about growing out of autism.
Right, right. Well, thank you. First of all, it's over 3 decades, believe it or not.
I don't believe it. You do not look old enough to have been doing it for that long.
Yes.
I wouldn't be telling people that.
Yeah,
They won't believe you.
But no, there's, we've always said, and it's been controversial, I guess, for many different reasons over different years. We've always said that some of our kids recover. Yeah. There's no question about that for me, because not only do I have kids that I treated when they were 2, 3, 4, 5, so on, who are now teenagers, or in their 20s and doing extremely well and are recovered, and functioning well in society. But I've also learned several things over the years. So, first of all, to address this, I'm really glad they did this study, first of all, because they contrasted individuals who were considered optimal outcome or recovered with individuals who have high functioning autism, I guess, and with typically developing individuals. And they really did see that these people were doing great in terms of language, the experimental group, or the group that they were really looking at. They were doing great socially and so on and so forth. So it makes headway in terms of the general society understanding that it is possible to overcome autism. But for the media to, I guess, if they have presented it in terms of you grow out of autism, I don't really believe that. I don't think I've ever seen that you would just simply grow out of it. Yeah. You do, and actually in this study even, they're now going to the phase of analyzing in detail the interventions and treatments that these optimal outcome individuals received, so that they can see what was the most effective. And they are concluding that early intervention is critical. So it would be sad if parents believed that just by waiting the child would grow out of it. It's like any other thing. The longer you wait, the more pervasive it becomes. And if you don't even really worry about how serious or how scary the diagnosis of autism is, and you simply think about the fact, if you just cut it up into symptoms, is how I look at it, and you think, okay, this is a child who has, typically a lot of our kids have some sort of biology that needs to be stabilized. And if you ignore that, that's definitely not going to get them better without any intervention. And if you ignore symptoms like language or social behavior or anything else, those are also not going to get better. In fact, they're going to get worse, because the whole, the reason that a lot of our kids develop challenging behaviors, I guess, is simply because they can't communicate, because they don't fit in, because they can't read social norms and rules and so on. And so they will develop more and more aggressive behaviors, challenging behaviors over time. So, and then puberty, of course, makes it even worse. But there are certain, you can't just let things be. On the other hand, the positive thing is that people are beginning to understand that with the right interventions at the right age and intensity and quality, the kids are able to overcome the diagnosis of autism. And again, I'm interested. I haven't read the details of the study yet since it just came out, but it's one thing to say that you no longer fit the diagnostic criteria for autism. So a lot of our kids, they go through the process of intervention and they will go from the diagnostic criteria of autism to, let's say, PDD. Right. So that means they have fewer symptoms than would qualify them for autism, but they still have issues. Right. Or the child might drop the diagnosis of autism and go to Asperger's diagnosis or any other diagnosis. But the whole concept of a diagnosis is that the problems that are present are prevalent enough to make it difficult or impossible for the individual to function adaptively in society. Yeah. So when you diagnose an adult, you're looking at, is the individual functioning well at work, at home with their spouse, etc. And when you're looking at children, are they able to function in school? Are they able to have friends, communicate with others, and so on? So if it's pervasive enough, I guess, if the symptoms are strong enough where the child is falling behind in any way, then it's a disorder. There's a problem and you can treat it.
Yeah, absolutely. Well, I so appreciate your comments on this because I do think we're going to be hearing a lot about this in the next couple of days. It's going to be in the news, and it did concern me as soon as I saw that grow out. If you read the rest of the article that the Daily Mail wrote, there are several other quotes in it where they are very clear about the fact that all of these children had treatment on board.
Absolutely.
And in some cases very intensively. And as you said, they're going to look at, how much and where. So I just really took issue with that headline, grow right. out. Don't want to send that message out to parents because there is work to be done.
Right.
For some of our kids, there is this optimal outcome, but it's a great deal of work and there's no guarantee, and it is not all children.
Absolutely. I mean, I will say, though, that all children benefit from behavioral intervention and from, obviously, from, helping stabilize any medical conditions, dietary, those types of things. Everyone benefits. But the amount of the benefits and how fast you can get the child to overcome some of the problem areas really depends on so many different factors. Sure. So some of the children do incredibly well. I mean, several of them. A lot of our kids are
There's one
college.
In my house who's doing very well.
There you go.
He's not yet recovered, but he is doing very well.
Right, right.
So,
and I think when you get to that point where, you really are learning from your environment, then you most likely will catch up from peers and from school and so on and so forth. But a lot of our kids are not even able to really attend to their environment yet and to learn appropriately. So intervention is the key to it.
Yes, progress is available for all of our kids. And some of what you're saying dovetails into the first question that we're going to ask, because you were talking about the whole child, taking care of the whole child, and how sometimes there's some other issues. Someone wrote it in and said, "Dear Dr. Doreen, if a child undergoes alternative treatments that evoke strong reactions such as yeast treatment or sequential homeopathy, when also undergoing ABA, how do your therapists handle the reactions? Do they prepare behavioral intervention plans? What is your opinion about undergoing such a treatments when also undergoing ABA? Please let us know. Thank you." I love this question because sometimes...
Very real.
Yes, it is. It's very real. And sometimes if you're doing something to take care of a medical problem, you'll see that there's a little bit of a reaction.
Things get worse behaviorally. That's right.
Yeah,
That's
and is that an opportunity to stop the ABA, or are the therapists trained to deal with that?
Oh, absolutely. I think you have to. Well, I mean, our therapists are definitely trained to deal with that. You have to And that is, it's a very good question, because so many parents will avoid doing these interventions together. For us, it's important to try to get the child stable as fast as you can from a biochemical perspective. And yes, yeast, for instance, if you're on an antifungal medication, sometimes the kids will have yeast die off and they will have reactions to it, which makes them just sort of more, if you take, I mean, I don't know if, you know, if I try a lot of the different medications that our kids are given, because I sort of want to know what the actual feeling is and the side effects. And antifungals can make you kind of, you know, dizzy, somewhat out of it, spaced out, difficult to concentrate, all this sort of stuff, although it gets less and less over time. It doesn't last that long either, the die-off. But it's very important for the behavioral team to really understand those types of side effects and reactions, and simply reduce demands and increase reinforcers. It's really that simple. And when you start a program, any program, and you're teaching it behaviorally, you start with a massive amount of reinforcement and very low demand. And then over time, you gradually reverse those. You increase your demand and reduce the reinforcers so that the child or individual is able to kind of generalize. It's the same exact thing here. If you think about it in any other way, like if you have to go to work and you're sick, the day that you go to work and you're sick, you simply don't do the harder tasks that are on your plate. You do the easier tasks, you maybe take a shorter day, more breaks, those types, and you're doing the same exact thing. You increase reinforcers, breaks, that's the type of thing, and perhaps prompt more, model more, go to the low demand tasks that you're working on, and you resume, you continue. You don't want to stop intervention, because actually the intervention after a while, ABA, after a while really becomes the routine that makes the child feel safe. Sort of, it's his daily routine, and the child has become accustomed to it. So I would never say stop because you're doing biomedical interventions. I really encourage parents to do both. Ideally, when our parents want to get started with us, we do all the biomedical stuff in the beginning while they're waiting for, let's say, funding or the reports and intake process and so on. And then by the time we get into the behavioral intervention, the child has already started to stabilize a little bit. But I mean, you'll have reactions from the child with various medications, there's no question. And that's another thing that's very important to do both together, is that your behavioral intervention, without going into too much technical terms here, you know, if you do a biomedical intervention, that is what you can think of it this way, that would be considered your independent variable. It's the thing you're trying out to see what kind of effect it has on your child. How do you measure the effect? Yes, a lot of parents will just measure the effect subjectively. Oh yeah, he seemed more aware, or he seemed to pay attention better. But hey, if you're doing an ABA program, the results of your ABA program end up being your dependent measure, your variable that tells you how the child's actually doing. In other words, if you introduce a medication or a diet or something, and your child suddenly first starts to like escalate a little bit, you keep going with it, and the child starts to improve and does much better now. Oh my gosh, you can tell the medication's working. In fact, I have data on a number of our kids, especially with antifungals, because I really do think yeast plays a big role. And I see with our kids that after a very small period of time, they accelerate their learning. And so that tells me that there's definitely something going on with the medication that's being given.
Well, this brings up a whole bunch of other questions that I want to follow up with. What is your opinion about, a lot of times when parents are going to start a biomedical intervention along with ABA, there is this moment of deciding, do we tell our ABA practitioners so that they're looking for it? Or do we not say something and see if they notice a change in behavior, because they kind of want to get a true read on what's happening? What is your opinion? Do you prefer that they tell or not?
That's a really good question. I think it would be a good idea probably to tell the supervisor, and then the supervisor doesn't necessarily have to tell the therapist what's going on. The reason to tell your supervisor is exactly this type of situation where the child is perhaps not able to focus, is more agitated, those types of of things, and you want to make sure that at least the key person on the team knows, because the supervisor can easily modify the program without telling therapists why they're modifying the program. They can, take it back a notch and make it a little bit easier so the child's more successful again. With therapists, the reason not to tell them is because they are the ones that spend most of the time with the child, and it's fabulous if you get therapists coming to you after a while and saying, I don't know what you've done, but it's working because he's doing great right now. And then that's just sort of a confirmation.
Absolutely. Absolutely. And we had our biomedical and ABA in an era where skills wasn't there. But now on skills, there's a really easy way for parents to be able to chart an event that we started in medicine. Or I used to keep it on a notepad on the refrigerator, and that would scatter, and
so it's hard.
But that it actually, a parent can enter it in on the timeline and say, we started this medication, and then look back 2 weeks later to see on the chart, and it's very clear what happened behaviorally during those 2 weeks.
That's what I love. It's the what do we call it? The multi-something timeline, or whatever.
The multidisciplinary
timeline, This is one of the graphs that it produces on skills, and so skills is automatically, as you know, producing a line of acquisition, which shows like how much the child's learning, and you can put in all the target challenging behaviors, and it'll track them as well. So you are seeing, hopefully, these target challenging behaviors decreasing and acquisition increasing.
Absolutely.
And if you input these events, like I started diflucan or whatever antifungal medication, you can see the corresponding results over time, and that's fabulous. I love that.
Very enlightening. Thrilled for people having that now. Wished I'd had that. I mean, I could put the two together, but to have that visual, I'm a very visual person, and I love that. Now I want to talk a little bit, because you mentioned die-off, and for people who are new to this and don't know about yeast and die-off, it isn't perhaps every child's issue, but there are a great many children, and my child was one of them, that yeast was an issue.
Right.
And we saw it very clearly. I guess it presents in different kids, but our child would get beyond silly. We would call him the drunken elf. He would get the tee-hees and even walk funny. And you could smell it on his head and on his breath.
Unbelievable.
He smelled like a fresh loaf of bread sometimes.
What was he on?
Well, eventually we changed diet, and eventually he did some diflucan, and a couple of other things that went along with it. And we did it during the summer months because what we saw, and we were prepared, both by our doctor and by our whole team, letting us know that it was going to get worse before it got better, that die-off thing that you were talking about. And I'm so grateful that I knew that component of it, because the behavior, and in our case, it got much worse for a while.
That's right.
And then it was like a light switch in one day. He was a different child.
But you're very lucky because it actually had a long-lasting effect. And this is one of the biggest problems I see with the kids who have yeast issues. And I think the common medications are either nystatin, nizoral, or diflucan. There's amphotericin. There's a number of them. But what I see with the kids is there's the very first time there's an initial die-off period where the child gets very silly and so on, but after that, the child you see a pretty significant change when your child has yeast issues and when you treat it appropriately. But the problem is it keeps coming back.
We do have that too. It cycles back, but never as bad as it was. It does cycle, and we really strive to watch diet and the amount of sugar that he gets in his diet. And by sugar, I mean he has no white sugar, but even fruit sugar. We have to ration fruit.
And see, that is, I think, the most critical thing, is the diet is what helps you manage the yeast from coming back. And you almost have to think about it as a lifelong type of thing, just like kids with celiac. I mean, you really do want to watch the food products that will increase yeast growth. And that's incredibly important, I think. Otherwise, you're always going to be doing this cycle of on and off antifungals, or some physicians will actually give you sort of a ongoing dose of antifungals, and you have to be careful with that, of course. But the change is so drastic
it was amazing.
that it's really important, I think, yeah.
And it was amazing for us because when the change happened, it was literally the week before kindergarten started.
Right.
It was optimal. It was an amazing sort of thing. But yes, we are very careful diet-wise, and still he'll cycle in and out. And I mentioned to somebody yesterday because he just went through the flu, and I don't know if other people at home experience this, but I can tell when he is getting a fever before anything else, because his language changes, and I can tell there's still that much yeast because the high temperature of his fever kills yeast for a period of time.
Right, so his language improves, you're saying. Yeah.
It's amazing.
Right, I know.
Absolutely amazing.
I know. Isn't
how
that
he
amazing?
speaks when right as he's going into a fever.
Yep. A lot of parents report that. And I think it is the cycle that you mentioned, and it's just fascinating.
Yeah, it is. I need to remember to videotape in those moments. You're worried about other things and getting the vaporizer ready, but
it's crazy.
He talks like he's in college.
Yeah.
It's amazing. I mean, the words that he'll use that I don't even know that he knows, I go, oh, if we could have that all the time without a fever. In any case, the yeast thing, it's an ongoing battle.
Right.
But the main question that was being asked there was about, do you stop ABA? And I think clearly you said no.
No, you don't. And just to go back and finish up on that, one quick thing is that sometimes I have parents who are doing so many different interventions at the same time, including, I had one parent who had 72 different types of medications or supplements and so on, vitamins, supplements, enzymes, minerals, you name it. And it's just impossible to tell what's going on when you have that much happening at the same time. So really, when you're starting any kind of medical change, I would do it a phase at a time. It doesn't, you keep your ABA program going simply just because it'll help you track things as well. But you introduce the medical or biomedical dietary, vitamin, nutritional changes one at a time, and let there be at least a couple of weeks period in between so that you can see the effect of each one.
Yeah, I think that's really, really key.
Yeah.
Thank you for adding that. Okay, we had another question about any suggestions for incorporating a social skills program using neurotypical peers into a card skills ABA home program. Any suggestions about that?
Well, absolutely. I mean, we have a process that we do for teaching social skills. We first start, I guess, with all of the core content skills that are necessary for the child's age, so that, the actual skill itself, being able to, read facial expression, being able to have a certain level of ability of knowing when to join a conversation, knowing how to interrupt appropriately, all that sort of stuff. So if the child has the core competency stuff, then the way that we phase into social interaction is we will go first with an adult, and of course the child is with an adult, that's the therapist, but we don't want the therapist because we really want an adult who doesn't know how to guide the child or prompt, just a typical adult, and see how interactions are with the adults. Typically our kids do much better with adults anyway. And then from there, one peer, which we call play dates, and the peer comes to the child's session, and the therapist will kind of moderate between the child and the peer. And when we've reached a certain level of mastery there, where there's a decent level of interaction between our child and the single peer, then we will start introducing groups of peers. So we won't go straight into a social group because that becomes too difficult for our child, but then we'll go to, let's say, 2 or 3 kids. And really that's the setting that you will have then in school, and it'll be the most common type of situation where the child enters. So yeah, we're always using typically developing kids to help our children model and know what they're supposed to do. I find that with our, let's say the highest number of our kids would be little boys, given the ratio difference in autism. And so I find that the best teachers for our little boys are slightly older girls. So like if I have a 4 or 5-year-old boy, then I'm looking for, unless the child's already developed a friendship with someone, then I would be looking for, let's say, a 7, 8-year-old girl, just because the slightly older girls are much more teacher-like, and they like to take you and lead you and model and teach and that sort of thing, whereas other boys tend to not have that same level of interest or patience.
Right. They're more laid back. You're always very politically correct about it, and I always say those girls are the bossy girls.
Oh, they're the best.
It's that age.
Yeah,
and
they're the best.
really remarkable. Yesterday we were showing the A word, and they were having a clinic, and in the clinic they were talking about scheduling outings.
Right.
And going to regular outings, and I was making the case to our families at home who are watching, when you have an ABA program, how, a lot of times there's this stigma attached to having an intensive ABA program that you're stuck at home with the child, and it's this intensive behavior, and that part of our job, as I see it as parents, is making it conducive to taking that program out of the home and giving it legs in the community.
Absolutely. Absolutely. Teaching the child. We do so many programs out in the community.
Yes.
I mean, you have to. How are you going to know if the child can function in a restaurant unless you actually go there?
Yeah.
A lot of our stranger stuff that we teach the child to avoid strangers or to be able to identify a stranger happens in stores,
Yes. And taking the therapist with you, the whole concept. I do hear parents say from time to time, oh, we did an intensive ABA program, but we couldn't do it for long because, I have grocery shopping to do, and I have Christmas shopping to do, and I have, this meeting to go to. And my answer always to that is take the therapist with you.
Absolutely.
It's one of my favorite things to take a therapist to a birthday party.
Right.
Because kids are going to behave differently around me than they will around a young adult who crawls into the bouncy house with them.
Right.
It's amazing the things that your child can learn at a birthday party with a therapist.
Definitely.
So making the case for that. And you can create, if you're doing the skills program at home, you can create that. You just need more adults
question
to be able to do
Absolutely.
that. Okay, great. Next question I want to do, we have a couple of different questions about sleep. So this one, how do I get my 5-year-old severely nonverbal son to sleep more than 90 minutes at a time? His melatonin levels are quote unquote normal. And we actually had another question on Facebook that I'll bring up too that was also, I believe, about sleep. Oh no, it's about obsessions and compulsiveness. I'll come back to that. But we had another question that was also about sleep. And I know we've talked about this a little bit before, but this 90 minutes at a time for specifically. And again, before you start, I want to remind everybody that we never want to be in the position of making it seem like we're giving child-specific advice.
I was just about to say that. Yeah.
It's a terrible disservice to your child to assume that you can write us one sentence and that even someone such as yourself could know every possible configuration of what's going on. Right. So I just want to remind everybody that Dr. Granpeesheh will give us some generalities that we can take and learn more from, but that we never want to make it seem as though we're giving specific
Absolutely.
advice.
And I think in these cases where there's so many questions that I would ask in order to be able to give an intervention, I will try to help the parents maybe understand some of the things they have to assess. So, if your child's, first of all, it would be a whole different story if the child is, let's say the child's sleeping for 90 minutes at a time. I'd want to know right off the bat how many times. So what's the total duration? What's the period of time in between these 90 minutes? And what's happening in between these periods of time? Because just like babies, I don't know, if you remember when you have a newborn, and if every time the baby wakes up, you immediately run in there and give them water or milk or something, they will be trained to wake up.
Right. It's a good time.
It's a good time.
You take care of me. I wake up.
It's not even. I don't think it's even a conscious decision. It becomes a sort of a physical chemistry type thing where you learn, just like we have learned. Have you noticed, like, okay, there's no such thing that you have to eat every, 4 hours or something. And people are very different in that. Some people need to eat every 2 hours. Others can go 6 hours, whatever it is. But we have breakfast, lunch, and dinner, right? So it's a time frame that we have mentally set. And if you don't have something at lunch, you're going to start feeling hungry just because it's lunchtime.
Right.
Okay, so it's the same thing with kids and babies. Their body goes on this calendar, on this schedule of, I need to wake up at these intervals because that's my feeding time. And so I don't know, typically the biggest one is feeding. Any kind of food, water, whatever will put your body in that type of schedule. So I don't know if with this child, the 90 minutes, every time the child wakes up from the 90 minutes, the most important piece of data that I'm missing here is what happens when the child wakes up.
Right.
Because if there's any kind of food, water, even social, like consoling the child or interaction with the child has gone into a schedule of these are the periods of time. What wakes the child up to begin with could potentially just be their body signaling, I need to get up now because I'm going to get some milk or whatever it is. Or it could be other things, which are, I'm going to go on the things I would assess when you have any kind of sleep disorder. I would really assess seizure activity. I'd want to go see a neurologist and make sure that, do a sleep EEG, figure out that there's nothing else going on with my child. Are there actually subclinical seizures perhaps that are waking the child up pretty routinely? But you need to really check that. That's very, very important. So then the biggest thing that I would be intervening with is that what happens in between the sessions. And again, I don't know, like maybe a child sleeps, in this case, maybe the child's sleeping 90 minutes and that's it. And then 4 hours later sleeping 90 minutes. And you have to be very careful because you don't want to be reinforcing the child's awake time during the night in any way. In other words, the child should really not have any other option but sleep. That's what I'm trying to say. So they shouldn't have the option of coming over to your bed. They shouldn't have the option of having toys that they can play with, because those are all going to be things the child's going to prefer over sleeping. And if you do that for about 3 or 4 or 5 days where the child really has no other option, and I know that it'll be difficult obviously because the child will not want to stay in their bed, and but they will gradually start to increase the duration of time. If the child's taking a nap at any other time of the day, cut that out. If, you know, there's so many different things that I would ask to find out more about this situation. I have found, and I've said this before, and this is personally for me, I also use it with my kids. I have found that there's you can buy it everywhere now. It's called Tranquil Sleep. It's it's a combination of tryptophan and melatonin, and I found that it's significantly different than just taking melatonin alone. For me also, if I take melatonin alone, which when I travel, it'll barely put me to sleep, it will, and then it'll wake me up shortly after. So melatonin actually itself has a cycle period too, where it wakes you up after a period of time, either 4 hours, 6 hours, depends on the amount and the type of melatonin. But when I have found that when it's in a chewable tablet together with 5-HTP, tryptophan, it will not do that. It'll be much, much better. It'll help you go through 6 hours at least and a really nice deep sleep. Other alternatives that the family could use if the child is healthy are things like Benadryl, which will actually just make the child a little bit more drowsy. In other words, with the consultation of your physician and after you've ruled out any neurological issues, what I would do is both a medical and behavioral at the same time, which is I would make sure that the duration of time that the child needs to sleep, let's say 6 hours minimum, the child is in their room and not able to interact or do anything else. It doesn't matter how much they complain about that. If they're healthy and there's nothing else going on, then let the child scream it through if they need to. Or you can also increase it gradually. You don't have to go straight to 6 hours. But your goal is to get up there. And so what you do is you help the child with some sort of medical, let's say, supplement, whether it's melatonin, 5-HTP, or Benadryl, or even some other type of sleeping aid from your medical doctor. And on the behavioral end, you make sure that the child is, you know, building up towards that 6 hours period at least, and then of course higher than that.
Okay, great advice. I want to talk just a little bit about the, you know, the expression that you use, the letting them scream it through and not having other things, just to clarify in terms of, because it's hard sometimes as a parent to know exactly, you know, I really think when you're in it, it's so different than looking at it it from the outside, because first of all, at that point you're tired and so on and so forth. So just want a little bit of clarification about, because I know recently somebody had said to me about that moment when if the child's getting up out of bed and what else is available.
Right.
And pointing out to me that I needed to be quiet and laying down with the lights out too, because otherwise if I had lights on somewhere, that he was going to be like a moth and coming to that.
Sure.
And so it doesn't necessarily need to be a battle, is that the case? But that, you know, having us not attend to what's happening, but not letting them have access to the toys and lights on and TV and games and us.
Right.
Is that?
And again, it has to do with the age of the child and the habits of the child. If the child has been sleeping with you, then that's an additional factor that needs to be dealt with. But let's assume that the child is in their own room and waking up every 90 minutes, and if they do, then they're possibly either coming to you or calling you. And that is when it becomes very difficult. And I'll be honest, most of the time it's going to be difficult. It's going to be very difficult. It's not like the child's just going to lay down and say, okay, they're not coming, I'm going to sleep.
Right.
It is going to be difficult because the child is going to want the comfort of being with you, of perhaps getting a bottle, of getting water and that sort of stuff. So you will need to be tough in this. You will have to be. There's no other way to do it. And like I said, if you the fastest way is just to say, this week I am going to have my child in his room for 5 or 6 hours. No matter what.
Right.
And you can put a camera in there, obviously, nowadays, and you can see everything that's going on with that child, really being aware of it. A slower way, which is perhaps more gentle on the parent, is to gradually increase so like the child wakes up at 90 minutes, don't interact with the child for another half hour. Okay. Right? And then now you've brought it up to 2 hours. Okay. And then the next 3 nights later, you make that 3 hours, and 3 nights later, you make that 4 hours. It's going to kill you. It's exhausting to do this. I mean, I did this with my last child. I used to sit outside her room while she was crying, you know, and I know the temptation, because you can't bear to hear your child crying, and you want to go in and do whatever you can, whether it's yell at the child or comfort them. Right. You're just at your wit's end. It's the middle of the night, and it's your 20th night or whatever it is, right? So. But you can't, because the more you interact with the child, you are just training the body of the child and the physiology of the child to just keep awakening at that time frame. And really, there's so many other things you can put soothing sounds, one of those machines in the child's room. You have to make sure that everything is dark. Right. Darkness really does actually help with sleep. There's all these other factors where you can make things a little bit easier, but it's not an easy process. It's not pleasant, but hey, it is fast, and it is definitely a learned behavior. Okay. It could potentially, that's why I said rule out neurological stuff. Sure. Because it could initiate with something biomedical, biochemical, but the fact that it keeps happening after the child, if you've ruled out everything else, means that it's really learned. Okay. Okay, which means we can change it. And you can change it, and it's more tough on the parent than it is on the child. Okay. Really. Fabulous. But and again, going back to this issue, I can't emphasize how important this is, because sleep is the most important factor for our kids to actually be able to learn. Like, we don't take into consideration when a child is waking up every 90 minutes, not only is he wiped out, exhausted, when you look at his biochemistry, it's going to be completely messed up. He's not, when you don't sleep 5 hours straight, you're not producing any adrenaline. A lot of your neurotransmitters are off now because your cycle has been messed up. So you're not producing all the various types of things that stimulate your body or help you focus or energize or communicate internally. Right. So learning is not going to be optimal, and coping is not going to be... It's just going to fall apart. Right. Child's going to be tired, tantruming, therefore failing at their intervention. It's just going to be a mess. Okay. So sleep is incredibly important. Okay, great. We're going to take a little bit of a break, and when we come back, we'll deal with a question that we had on Facebook about obsessions and compulsions. Great. So stick with us. More with Dr. Doreen Granpeesheh.
Granpeesheh after these messages. Welcome back to Ask Dr. Doreen. We're here with Dr. Doreen Granpeesheh, a brilliant, brilliant visionary in the field of autism. So thrilled to have you here. We're answering your questions. There are a lot coming in. I know we're not going to get to all of them, but we're going to try to get to as many as we can in the next few minutes. But keep them coming in because we'll get to them next week and the weeks after. Somebody wrote in on Facebook, what is an effective and natural way to help a child with autism deal with their obsessions and compulsiveness? There's a blogger that I love who posted not too long ago, you know, most of the time I'm fine, but every once in a while I want to take autism and her twin sister anxiety out to the woodshed and whip them.
Yeah.
And a lot of us went, oh, you're singing my song.
Yeah, absolutely. Absolutely, and I've talked about that a lot as well. In fact, I think in March I'm giving a keynote presentation on just the topic of anxiety here somewhere in Orange County.
Okay, let us know when that is approaching because that sounds fascinating.
So this is a big issue. All of the, you know, what we call in the diagnosis of autism, the self-stimulatory behaviors, in my opinion, the majority of them are connected to anxiety. And OCD, or obsessive compulsive disorder, is one of the anxiety disorders. So there's 6, and OCD is one of them. And so when you see obsessive compulsive behavior in autism, you can be pretty certain that the child is experiencing some form of anxiety.
Okay.
So then you want to start thinking about, why is my child feeling anxious? And the reasons can be a million different reasons, obviously, and this is why it always helps, I think. I tell the parents that I work with, just stand in your child's shoes for a minute, like really see the world from his or her perspective. It's very important because you will see that if it's let's say a highly impacted autistic child who has very little communication ability, the minute that they become aware of what's going on around them, they will feel anxious because they are aware of it, but not able to comprehend it, not able to interact with it, not able to figure out, problem solve, and get their own needs met. I mean, that produces anxiety. I could list a billion things that produce anxiety, like not only environmental factors and the fact that, you know, I always give the example that when I was in Hong Kong a few years ago, I was really, really jet lagged, hadn't had a lot of sleep, had a lot of coffee to stay awake and keep working, and couldn't read anything, any signs. I was lost, couldn't find my hotel, extremely dirty environment, downtown Hong Kong, lots of lights and noises and so on. And hey, I mean, that was anxiety, you know, and all I wanted to do was get back to my hotel and put down the shutters and lock the doors and just get in bed, you know, which is really how our kids react as well. So environmentally, you have to, the very first thing, you know, when you see OCD in a child, you have to, first of all, you have to figure out, is it chronic? Is it does the child feel anxious in all settings, or is it certain specific environments that are making the child anxious? So if you're in specific environments, let's say school, or parties, or anything, you know, like you find children who become extremely obsessive compulsive when they go to a party, that for me is an immediate connection. Oh, okay, it's the sound level perhaps, because it's so much different at a party or at school. Maybe it's the demands. It's just that the child's becoming more aware of the other peers and realizing that he or she can't fit in. Embarrassment. It's the stuff we want our kids to develop.
Yeah.
And as they develop it, obviously they're going to be anxious. You know, embarrassment at a high level is anxiety.
Yes.
So when you want to change the environmental factors, so that means you want to make sure that the child in those settings is much more reinforced, there's much more modeling or prompting going on. Make the environment easier for the child. In other circumstances, it's not environmental, but it could be just medical issues that are leading to anxiety. For example, if your child has a lot of GI issues. I don't know if you think about it yourself, if you have a day where you've had something that doesn't settle well with you, and you're back and forth in the bathroom or whatever, and you have, let's say, diarrhea, the feeling that accompanies it is anxiety.
Yeah.
It's kind of interesting. It's not really anxiety. It's anxiety just because it's a stimulated state it's an agitated state. So your biochemistry could be in an agitated state, and we see that with our kids who go to the bathroom like 10 times a day or have bowel movements 10 times a day. Those kids are for sure going to have a certain level of anxiety.
Yeah.
No question. How about the sensory issues with our kids? Our kids, the ones that love to be held and squeezed and their skin pressed, well, guess what? That's because most of the time they feel like their skin's crawling. That's a sensation that's very similar to anxiety. So all of those types of things could be potential reasons. And, you know, from a behavioral perspective, I suppose, you identify those and you try to fix them, right? If it's a sensory type issue, you want to make sure the child is getting, these are children who would do very well with the weighted vests.
Right.
When you really give the child a whole diet of, or a regimen of having tactile stimulation so that they feel calmer. Yeah. Do the correct sensory interventions so the child can feel more safe or calm. With the biomedical issues, obviously try to treat the stomach issues or anything else that might be causing the child to feel that way. And with the environmental factors, again, try to change the environments, make them less demand, higher reward. It's always that formula that makes it successful for our kids.
Okay.
And you know, I think the parent had written natural ways of dealing with anxiety. And the interesting thing is that, you know, melatonin leads to the production of the combination of this is the stream that is sort of like tryptophan. Melatonin does affect the serotonin, one of our neurotransmitters that deals with anxiety. And so when you have a child, so you could also go that route and do the natural forms of serotonin. That would definitely be helpful in some kids.
Right.
And when you go to medicine, the SSRIs, or the selective serotonin reuptake inhibitors, are the medications that are given for anxiety, and they are serotonin. You know, they stop your own body from reuptaking the serotonin in between the cells, so you have more serotonin.
Right.
So increasing serotonin levels should typically help the child to calm down a little bit. And so, you know, those are some just very, very general overviews.
Absolutely.
Yeah.
Okay, thank you. Really informative. We have somebody who wrote it and said, first, they love your new haircut.
Oh, thank you.
Second, my question is, my third grade mainstream son can sometimes pass for being typical. I have a sense of guilt when I enroll him in adaptive lessons, always questioning my choices like, does he really need extra help? Would he be better off without extra help? Am I holding him back? He has a full-time aide in mainstream school. I ask myself, is the aide holding him back? Then again, I wonder if all supports disappeared, would he regress? I never know what is right, and it's so frustrating. Thank you. And I think a lot of us can relate to that, about there comes a point when, you know, and it's a quality problem.
Yes.
When our child is doing really well, and how much support to have and how to fade it, I think is a big question.
Right, and that's, you just gave away the answer.
I did? I didn't hear it. Tell me.
I mean, it is really just a matter of, you don't just pull the support, you fade it.
Okay.
And so really the answer is, I would say that the best thing you can do for this parent is to just have the aide, first of all, be a little bit less involved in, and we always transition our aides out. We never just pull them.
Yeah.
So you will have the aide be less and less involved with interaction with the child. In other words, the aide will go to just sort of standing behind or standing at the back of the classroom, only coming forward when they're necessary, that sort of thing. Then you can also go to, if you're working with an agency, what we do is we put a different aide in who is an unknown aide to the child. So it's kind of a confederate aide. It's someone that's not, the child won't recognize as their own therapist, because there's going to be a level of dependency between the child as well. So we'll put an aide in the classroom, and the the teacher, of course, knows what's going on, but the child doesn't know that this is one of their therapists. And the aide will now help the teacher with everything, anything the teacher wants, including, of course, keeping an eye on our child.
Right.
So that's another stage of fading out. And then you will gradually decrease the presence of that individual to different time frames. Like if with a lot of our kids, they're doing great in class, they need a little bit more assistance, perhaps on the playground or at lunchtime, those types of things. So we will have the aide only be present in those time frames and then gradually decrease that and fade it out. And if at any point you see that the child is falling apart or really does start to deteriorate in how they're progressing in school, then you will want to reinstate the aide.
Yeah.
This is something that you're really working very closely with the teacher, because as your aide fades out, the teacher needs to be fully aware of what's going on, and you have to be sure that the child is responding 100% to the teacher, even better than they respond to the aide, so that the teacher takes what we call stimulus control. So the teacher has control over anything and everything.
Right. Is it me, though, that it feels like schools don't understand this progression? That, as I was listening to you describing the optimal situation of fading an aide, it's the complete opposite of what usually happens at an IEP meeting and what is stressed by the school. The first place that they take the aide off of usually is lunchtime and the playground. Right. I hear that so many parents frustrated with that, and that they will often take the aide, they fade the aide out at a time when it's conducive for them, which is usually the end of the day, which is when the child needs the most support. There is a frustration that I feel that, at what point are schools going to start to listen to organizations such as yourself to understand the proper way in which to do this?
And I think I guess we have to be careful, because there are some schools that are really good at this, and other schools that really are overwhelmed and can't deal with these issues. I think it is more the responsibility of the lead ABA person, the supervisor, let's say, in our organization. It's the supervisor that attends IEPs with the parent and the school. And if the supervisor is able to explain things just like I did right now, I have no question that the school will generally, most of the time, understand exactly why we want the aide and how we want to reduce the 8 hours. I think in most cases for schools it's just a budgetary issue, and they want to drop aides as fast as they can. And I think that if we're able to tell them, okay, we'll get there in 3 months or in 6 months, but this is how it needs to be done, then it tends to work out a little bit better. Having said that, I mean, there are schools that won't even allow us on campus. So it's important for everyone to kind of come together and make decisions that work. And I think we may be getting there, Shannon, just because I think the whole system is changing now that there's insurance coverage. Because schools, I think, feel less of a burden in terms of the financial aspect of things, and so they might become more collaborative.
I hope that you're right, and I appreciate you pointing out that some schools are already getting it, and more and more schools are getting it.
Terrific.
And when we can explain to them, I do think that they, for the most part, schools want to help our children. I just think sometimes they don't have the training and the knowledge, but we can more and more provide that.
Absolutely, and that's very true. And we are providing a lot of that on IBT, on our behavioral training website. And sometimes we have to understand that the entire world of ABA consists of very young people who have gotten a degree in behavior analysis and are now going into schools telling these teachers who've been there for 20, 30 years what to do. And that is difficult for anyone. You spend your entire life. I mean, I think I work a lot on trying to be a humble person. Like, humility is important to me, but if someone at this point in my life came and said, by the way, everything you've been doing is wrong, and from now on you need to do this, I think I'd have a very hard time with that as well. So it's understandable, I think, for the teachers to be a little reactive and to kind of question a lot of the stuff that we do, especially teachers who are strong and they don't even realize that they've been doing a lot of behavioral stuff well. And so it just needs to be a little bit more collaborative, I think.
There you go. Well, we will definitely work towards that.